receive webinar certificate only after filling both the attendance form. This webinar would not have been possible without the support of the PBS as forming institution. For that, let's listen to remarks from the head of the study program, Professor Asmarina, Magister of Science. Is Professor Rina already attend? Okay. Okay. So I think Professor Rina has not attend yet. So we will continue to our main section, which is topic presentation. Therefore, let me invite Dr. Chyntia Jasirwan, internist specialist, as our moderator. Yeah.
Yes, thank you very much, Dr. Nurinda. But first of all, I would like to confirm, is there any someone other from the biomedical will be replace the place of Dr. Asmarina? No, will not give the first speech.
I think no.
No, okay. So, okay, thank you very much. Hello, everybody. Assalamualaikum warahmatullahi wabarakatuh. Welcome everyone to our session today. We will talk today about artificial intelligence. And actually, we have a very interesting session for you all, and are fortunate enough to be joined today with two keynote speakers. The first speaker is Professor Hanry, and the second speaker is Professor Budi Wiweko. Okay. First of all, I will introduce you Professor Hanry, that will be the first keynote speaker today. Professor Hanry, PhD, he come from Singapore, and his education background, he is the expert in certificate in 3D microscopy of living cell from Columbia, and also PhD in cell biology in Duke University, Durham, North Carolina, USA. Yes? I'm sorry? Oh, okay. And then he also got the certificate in analytical and quantitative light microscopy, marine biology laboratories in USA, and got the EMS in molecular biology and biochemistry in Washington University Medical Center, St. Louis, and also got his bachelor's in biochemistry in high honor, Michigan State University, Michigan, USA. So actually, if we listen, we know about his education background. He already around the world, and also long life in America. And his current position now, he is as the tenured professor in School of Medicine, National University Health System, and also the professor in University Scholars Program and in National University of Singapore, and also the group leader, Institute of Bioengineering and Nanotechnology, Singapore. He also as the principal investigator in Singapore, and also the director in NUHS Research Core Facilities about the confocal microscopy unit, and also the co-lead principal investigator in critical analytics for manufacturing personalized medicine, and also Singapore MIT Alliance for Research and Technology, and also as the faculty member in NUS Graduate School of Integrative Science and Engineering, and also faculty member, a STAR Graduate Academy, and faculty fellow in Singapore MIT Alliance. And also, he already published so many research in artificial intelligence and also in pathology anatomy. His publication is almost around 150. No, I'm sorry, not 150. More than that. Around almost 200 publication. And I think we can continue from now to hear his lecture about the artificial intelligence in telepathology. I would like to give the place to Professor Hanry Yu. Hello, Professor Hanry Yu.
Yes.
The time and the place for you today, and your time for presentation around 35 minutes.
35 minutes.
Yes.
Okay, so I will go fast.
Dr. Hanry Yu. Thank you very much.
Let me share the screen.
Yes.
Give me a second. Okay. Let me see. Okay, so you see me.
Yes, we can see you, Professor.
Okay. Good afternoon, good morning. So I'm going to talk about artificial intelligence enabling telepathologies. As you hear from my background, I'm a mixed bag of everything. So I'm trying to interface between engineering, computer science, and medicine, some aspect of medicine. So firstly, I'd like to thank all these people that has supported my research as listed here. The reason for having an engagement of all this institution is not because I want to do many things. It's basically because they provide some funding support and other facility support for my research. So, well, there are decreasing number of pathologists in the world, as you probably hear, with more inventions of non-invasive methods of diagnosis. Radiologists has been increasing and pathologists has been decreasing. So as I talk with many of my colleagues in pathology departments, they are lamenting about the expertise is losing. So at the same time, they are increasing number of needs, especially in the remote area, which is better connected nowadays through internet, through mobile network with the cities. So therefore, the workload of my colleagues in the cities, in the pathology department, has been increasing. So this sort of bring out the issue, sort of attracted my attention. And as a result of that, I started working a little bit more on how to facilitate the process. And so telepathology is actually a mode of enabling pathology services to be provided to remote areas. Oops, sorry. Yeah, so a paper listed here in 2002, a very old one, just to illustrate that in order to transmit information from remote sites to city hospitals, there has been a lot of informations need to be transferred. Primarily static images or videos, or a combination of two. The videos mostly is endoscope images. And in some cases, some types of visual inspections. For example, for skin cancer and others, people start using mobile phones to take pictures and transmit information. In 2016, there was a list of services. There are some examples of the services the industry or the non-profit organizations are providing to link the people in the remote sites with the pathologist network. Many of them are retired pathologists in the West, providing services to the remote site on consultation basis. And one of the companies was the company that I helped to set it up, but they stopped providing the service very, very quickly. Because, well, it's a very interesting area which I will talk about a little bit later. So basically what happened is that they provide portals to link the remote site, to input the images, videos, and such, and transmit it to the network of pathologists to perform analysis and provide advice, and then feed it back to the remote site. So this is what I call a centralized models or uploading models. That is, the remote informations in the remote site or clinics or hospitals are transmitted through internet, through various means, to the central expertise in the cities. And then after that, the information's advice is feedback to the remote site. So much of the burdens of the collections of images and preparation of the samples have to be done in the remote site, which leads to a lot of problems in terms of the variations of the quality of the images. And also the transmission of the images, the quality is highly variable. And not only that, the workload for the city hospital pathologists is very heavy because everything is sort of centralized and bottlenecked in the city hospitals. So as a result of that, it has been proposed quite many years ago that there's a need for distributed models. That is, somehow computers can convert some of the expertise of the knowledge of the pathologist to be distributed to the remote site. And then the remote site CAD, the computer-aided diagnostics systems, can perform two functions. One is to aid the local clinicians to make some decisions, and at the same time is to facilitate the digitizations, the sample image collections, and transmissions of the images to the central site. So more or less, it's a more relieved models of the centralized systems. The burden is somewhat relieved, depending on how good the computer system is. Okay, in the more recent years, artificial intelligence has been growing tremendously to facilitate and enrich the CAD systems, to enable this distributed aid in the remote sites to be more efficient and more expert-driven. Sort of like that. I will explain, it doesn't work exactly like this in this ideal model, ideal scenario. So what is artificial intelligence? In fact, artificial intelligence has been a buzzword many people talked about. It's quite wide, by the way. It includes things like robotics, gaming, machine visions for navigation, self-driving cars, and data analytics. For medicine, most of the people are actually thinking about data analytics. The data analytics approach, such as machine learning, and its subset of the discipline is called deep learning, has become really drawing a lot of attention. The reason why deep learning attracted a lot of attention with great potential especially for telepathology, at least people think like that, is its self-learning ability with minimal supervision once it has been properly trained. You can imagine that the expert in the SOTA hospital can train the system with large data set collected from everywhere. Then you can use such an agent, trained agent, to test new cases remotely with minimal supervision. In other words, the expert in the city center hospitals have created many clones of themselves and send it to remote site in a distributed model of telepathology. This is sort of the ideal scenarios. Does it work exactly? Well, the general concept works. I will demonstrate in the next few slides sort of some ideal scenario when the data is good, the variation is not so inconsistent. You don't really need much of the adaptations. So such a deep learning approach actually works reasonably well. So basically, what is the difference between the machine learning and the deep learning? The deep learning in terms, I try to use the non-computer terms to explain this. Basically, let's say you take a raw images, and then in the machine learning mode, that's a more classical way of doing things. That is, you extract a feature through image processing and image analysis. Then you select the features, and then you identify, you train the system using ground truths to identify the features which is the most relevant to the staging or scorings you want to analyze. You try to classify. Then you build a classification system by putting some weightage, by putting some of the, build a model for that. And eventually you generate an output, which is some kind of scoring or staging of disease. Whereas the deep learning sort of take this whole chunk of the intermediate steps, such as the feature extractions, selections, and classification, sort of, well, classification, they kind of replace it, but mainly the feature extraction part, and even the selection proportion, they try to automate the process by having, instead of you manually trying to train the system to extract the relevant features, what you do is that you learn from a bunch of very large data set in the world. Sometimes it's relevant, sometimes it's irrelevant. And because the data set is large enough, so the pattern can be, relevant features can be sort of extracted automatically by the deep learning convoluted neural network systems. So this sort of automate a lot of processes, make the semi-automatic process of the machine learning to become more automated process of deep learning. So that's the attraction people have. As a result of that, people becomes very excited about it. And you see Nature papers coming out every day on this kind of things. More recently, people can just right before this webinar, I was talking with my student sitting here, who was showing me that there is a protein structure predictions by using machine learning. In fact, people have using deep learning approach to try to image things without imaging it. That is so-called virtual microscope and things like that. So it seems to be a very exciting field. Okay. Now I will try to use illustrations of scoring liver fibrosis, which is the work which we have done in the past 10, 12 years. We study liver fibrosis. We moved to NASH, non-alcoholic steatohepatitis. And I will talk a little bit about using the machine learning and deep learning approaches to study liver fibrosis staging to facilitate that process. And try to illustrate it to you that there's pros and cons of deep learning and machine learning in general, expert system, how one needs to be careful in terms of what to do with it. Okay, So basically, the liver fibrosis, as many of you probably know, that is a disease which leads to scar formations in the liver, which is, excessive accumulations of collagen or other types of fibers in the livers, and there are inflammatory responses leading to many disrupted phenotypes such as venopathies and such. So there's a structural features of the liver which is damaged, which is affected, as well as there's excessive accumulations of collagen fibers. So as a result of that, many of the diagnostic approach tends to be focusing on the collagen accumulations. For pathologists, the collagen accumulation is not just the amount of collagen accumulated, but also where the collagen is accumulated. So I would like to use this to illustrate the pros and cons of deep learning and machine learning approaches. So as I said, for the collagen, usually people use 3 different types of the stains to stain the slides, such as serous red, such as Mason trichrome, and the reticulin stainings. So the serous red staining usually stains many types of collagens, and Mason trichrome stains type 1 collagen fibers, and reticulin staining stains the type 3 collagens. And so there are many different scoring methods, staging methods for liver fibrosis pathology. I will just use illustration using a common one, a metaverse systems, which separates the fibrosis into 5 different stages from F0 to F4. F4 is the most serious, which is the cirrhosis stage. Use that as a ground truth. We engage a very experienced pathologist to liver pathologists to provide the ground truth scoring of the systems. So firstly, so before I go into the deep learning and machine learning approach, this is a summary of what I just told you so far for AI-aided liver fibrosis scoring. So you process the specimens to obtain the biopsy slides and process them, stain them, and then you sometimes image them, and then you transmit the images from remote sites to the center site for pathology reviews in the uploading models, or the other way is the downloading models or distributed models, which I talked about. So now, in terms of the pathologist analysis using the computer-aided systems, especially deep learning approach, the greatest success in the past few years is it seems to be using this most automated approach called transfer learning. That's the state-of-the-art approach. What is transfer learning? Transfer learning is basically use a large data set which is pre-trained in somewhat irrelevant or somewhat related areas. For example, if you want to build a database of, let's say, endoscope images of or videos of all the colon cancer patients, it's the number of patients or the number of images and videos you can obtain is very limited. So as a result of that, what people have done is taking all the images in the world, like a Google Net and things like that, which contain all kinds of images, and pre-train the system to recognize some features. And then you then refine the training by using your relevant images or ground truths. in terms of different stages. So to apply such transfer learning to our problems of classifying liver fibrosis. So this is an illustration of different stages of samples. What the system has done. This is a comparison of using transfer learning approach. You notice the collagen extracted in the green down there is done by the transfer learning approach. So as a result of the transfer learning approach, which can recapitulate much of the features of what the pathology is really caring about. So with this kind of deep learning capability of using transfer learning, in our case, in this particular case, it works reasonably well. The reason is because we use this image which is very good. And that means the images we use is really has low variability, low variations. You notice that the bar down here is the illustration of the higher the bar, the better the performance is. The closer to the one, the better performance is. You notice that using such transfer learning approach, that means automatically let the system extract features, and they seems to perform reasonably well. That means all the bars are close to one in many scenarios. I don't have time to talk about more details, different combinations of the staging here. Yeah, so, but you know, when you apply this to the hospital data or sample data from one single hospital, it works very well. But when you try to apply this to remote site, multi-center data, it doesn't work as near as well as it works in the single hospitals. So basically, there are two scenarios for the remote site. The remote site can have a scenario one, which is remote users who has a very limited data set, such as in a single village clinic. You don't have much data. You can only apply the CAD system to just use it and predict the new cases. You don't have enough data to retrain the system at all. Another scenario is remote users has enough data to retrain them, such as in a secondary city hospital, which there is enough data to retrain the model which you have created, either using transfer learning or using different kind of training system in the city hospital. But the problem is those are secondary hospitals in the secondary cities tends to have less expertise to ensure the quality of the images and the sample preparation. So therefore, they have very high variations. So as a result of that, in these two scenarios, try to apply it. So we try to apply this deep learning approaches, CNN convolutional neural networks, to situations we have a new data set from different hospitals in different countries. And we noticed that for scenario one, the performance is not near as good as the local validation. That means that you look at the accuracy, instead of 0.7, 0.8, which is now it becomes 0.4 or 0.5. And when for scenario two, the performance is slightly better because there is a local retraining model. So as a result of that, there are some local adaptations of the models, which improve somewhat the performance. But the picture on the right shows the images of what the neural network system is actually recognizing. For example, in stage 1, stage 2, stage 3, and stage 4, the red signal is what the system is recognizing. You expect if it's a good recognition, then they should pick up the samples. But in reality, the red signals is everywhere. That means the system is not recognizing any particular things in the image, but it's just remembering the images, okay? So as a result of that, deep learning work, might not work very well if the data set is rare, is highly variable, doesn't have a large data set to retrain the systems. So as a result of that, so we have a hypothesis is that if we can normalize the variation to ensure that the signal coming from different hospitals, different clinics is better correlated with each other, i.e. has less variation, has less noise, then it works very well. So one approach we have adopted in about 5 to 10 years ago was to develop a computer imaging systems which enables the visualization or detection of collagen from the biopsy sample without staining. When you don't need to stain, you reduce this one variations. So using such an approach, I will quickly go through it. That is when the variation this is images of collagen and the biopsy samples without staining the samples. And by using such an approach, you can actually generate very high quality data in terms of using deep learning or machine learning approach. This data is using machine learning approach. In 2014, we published a fully quantifications of Q fibrosis, leveraging onto the second harmonic generation microscopy, which is a label-free, non-staining approach to quantify liver fibrosis. But the problem is that even though this leads to a company which is doing well and sells machines, but the machines is expensive. So for many remote sites, it's very difficult to actually to produce or to acquire such machines in order to improve the quality of the diagnosis. So as a result of that, we hypothesized that maybe we need more expert domain knowledge in the classical machine learning approach instead of deep learning's automatic feature extraction approach in order to classify the collagen types and the collagen distributions in the standard staining images, regardless of what the staining and imaging quality is. So to cut a long story short, basically, we use k-means to extract the different color informations, I'm running out of time. So to extract the different color which represent different types of the collagen in different places. And then to generate a classification model which really works quite well. Okay? And this system in itself, we tested how robust the system is in terms of using the imaging of a normal bright field microscopes or use a high resolution tissue scanners. We extract the collagen distribution using the k-means methods, compare that with the label-free staining methods. It's almost exactly the same, but we don't need to use expensive microscopes to perform the work. Just computationally, we can achieve the same kind of staining extraction of the collagen distributions from the samples. So basically, this algorithm is to learn from the pathologists exactly how they care about the distribution or accumulation of collagen fibers and the destruction or damages of the tissues in the liver. And the weightage is, okay, I'm done. The weightage is created by the system automatically, and this different types of collagen ratio is determined exactly by the system, which is similar to what the pathologists actually care about, the fibrillo or portal collagens, how much it is and such. So basically, using animals and multi-center clinical data, we generated a highly robust systems which allows classification of stages of different fibrosis disease with very high accuracy, 0.9 or above. It can tolerate image quality deteriorations. It's also very sensitive to the early scoring of early fibrosis, which is not possible with conventional methods. And it's insensitive to imaging modalities. It's an expert system which performs much better in scenario 1 and scenario 2 of the scenarios that I talked about in the telepathology scenarios. And so we also allows for each of the staging, we can extract the samples similar to that to identify exactly what types of the basis that the system is making, similar to what the pathology is making decisions on. And we also provide a portal for people to download, so therefore they don't need to submit information that's sensitive from the patients to any companies, to any services. They can perform the analysis locally as well. So I think I will just quickly end here. I'd like to thank all these people, the students and collaborators and the funding support and thank you for your attention.
Thank you very much, Professor Hanry. Would you like to wait until the second speakers
yes, please.
do the presentation? Because we will have the discussion after the second speaker give the presentation. Is it okay? Do you have any other schedule after this?
I have a meeting at 2 o'clock, so I'm fine.
Oh, okay.
Now it's 12:10.
Okay, so you can wait.
Yes,
Okay, thank you very much to Professor Hanry. Okay, I think we can go to the next speaker. The next speaker would be Professor Budi Wiweko. Professor Budi Wiweko is the professor in Faculty of Medicine, University of Indonesia, and he is the president of Asia Pacific Initiative on Reproduction Aspire for 2018 to 2020. And also, he is a vice director of Indonesian Medical Education and Research Institute, Faculty of Medicine in Universitas Indonesia. And now he serves as the president of Indonesian Association for IFF, and also he is the general secretary for Indonesian Society for Obstetrics and Gynecology. And actually, he is former research manager in University of Indonesia, and he did a lot of contribution in developing IFF field in Indonesia, and also the founder of Indonesian Association for In Vitro Fertilization. And his research is about AMH, ICOS, and he also got many awards nationally and internationally. And for today, he will present about artificial intelligence in reproductive medicine. I would like to give the opportunity to Professor Budi Wiweko. Please, the time for you around 35 minutes.
Okay.
Thank you, Prof.
Okay. Thank you very much, Madam Chairperson, Dr. Chyntia, for very nice introductions. Good afternoon, ladies and gentlemen. So I'd like to continue our discussion today with the title of Artificial Intelligence in Reproductive Medicines. Sorry. Yeah. Okay. Yes. We know this is a Louise Brown. She's a first IVF baby, was delivered in 1978. And since then, IVF did not just fundamentally change reproductive possibility for the mother, but it did so for the father as well. Yeah, it is because we can doing injection one sperm into one oocyte that we call it intracytoplasmic sperm injections. At the time, human gametes could be fertilized outside of the mother's uterus, for instance, where the production would be possible for no other way. So right now, after 42 years of IVF, yes, many breakthroughs were delivered in all over the world, trying to increasing and also improving the quality of services of IVF, including the success rate. So that's why many breakthrough, many development on optimizing biomarkers, and then using the big data, we also develop in terms of reproductive medicine, that we call it precision reproductive medicines, and also the role of artificial intelligence, which is very important, how technology is bridging the gap in reproductive medicines. As the first speaker mentioned, Professor Hanry, that the the AI is very important. With AI, we can use AI to make a data analytics that coming from the clinical side and also coming from the laboratory side. Not only clinical data, but also genomic data. That's why we call it big data. And then we can use artificial intelligence to make AI modelings and then make predictions that we can use in our daily practice, even for diagnostic, prognostic, or also for the treatments. So that's why high performance medicine is very important. Very nice data presented by Professor Hanry in previous lecture, the convergence between human and artificial intelligence. We should realize that artificial intelligence or AI will increasing our task, increasing our responsibility to solving the clinical problem for our patients in the clinics or even in the operating theater or in the ward. This is very important. AI is not replacing the doctors, but AI will helping the doctors to solving the clinical problem. And technology is an enabler of the precision medicines. As we know, we had a lot of technology that can improving our services, that and endorsing how the patients can report their data passively or actively to the center, to the service, to the server, and then can provide the data, can provide the algorithm to the clinician for daily practice. Yes, AI, I think it's already introduced by Professor Hanry, first coined by John McCarthy in 1955, and this is a defined as an ability of machines to learn and display intelligence. Yeah, now it's AI growing so fast, rapid growth over the past few years, moving from the experimental to the implantation phase in various fields, including medicines. And very important, the advances in the learning algorithm and theory, the availability of large data sets. This, I think, is very important, particularly in our country. If we don't set the good electronic health record or electronic medical record, it's quite difficult for AI to be developed, because the availability of large data sets is the key important point if you want to establish artificial intelligence. Yeah, this is already explained by Professor Hanry in the previous lecture. So the next question is, why does reproductive medicine require artificial intelligence? As we know that in the field of IVF or test tube baby, the good quality of oocyte is very important. The good quality of sperms is also are determinant factors, for us to creating a good embryos that will achieve with the high success rate of the pregnancy. So the quality of embryo is the most critical factors of the success of the IVF. But however, still a lack in the method on judging how good quality of the eggs, sperms, and embryos accurately. Up to now, still there is no the best method, the best tools for us to assessing this is the best embryos, this is the best oocytes, and this is the best sperm. So this is difficulty that we are facing, yeah, to predict the probability of successful pregnancy for each patient. This is interesting data from oocyte to baby. Yeah, a clinical evaluation of biological inefficiency of IVF. Yeah, we can imagine from 7,200 oocytes. The total number of transferred and frozen embryos only 2,000. So utilization rate of embryos only around 30%. And amazingly, only 5% of fresh oocyte produce a baby. So that's why we can imagine this is one of examples biological inefficiency of in vitro fertilizations. So that's why we need tools. We need AI to predict which one is the best oocyte that can become a good embryo and also the good healthy baby. So we need tools. Yeah, we need assistance for us. So that's why developing AI is very, very important. Yeah, it's already explained by Professor Hanry, machine learning, NLP, and also robotics. Yes. Yeah, machine learning is a subset of AI that enables the computer algorithms that very important to developing model from the big unstructured data. So we need the machine learning to analyze this data to become algorithm, and also NLP. NLP is very important to extract and process meaningful information from unstructured clinical data, such as electronic medical record, to complement, to become the structured, and then also convert the raw data into structured data that machine learning can read and analyze it using machine learning technique. Sometimes we use NLP to convert doctors' conversation into written in an electronic medical record. Okay, in the field of reproductions, big data means we need to research a vast amount of patients and integrate with the various type of data. Using this type of data through AI hold great promise for identifying patterns that are beyond human understanding. This is very important. Big data is not just a new technology, but this is close the gap between the data availability and the ability to turn the data into information and into knowledge. This is for example. This is how the picture that we can explain how big data include electronic medical records and other data can capture data from various ways, and the data is analyzed using AI, such as machine learning and NLP, and then has been used in many aspects of reproductions, from research and experiment to clinical practice. Yeah, I think this schematically views the 7 main application AI in reproductive medicines. This is for research and experiments, robotic surgery and outcome predictions. This is for clinical practice, sperm cell classifications. We use AI to predict which one is the best sperms. We use AI to predict which one is oocyte, the best oocyte, and also which one is the best embryos. And even we develop AI into clinical practice, becoming clinical decision system, and also including the cost effectiveness assessment. This is the flow chart. Provide a brief overview of the AI workflow. Of course, the first step, very important, the collection of data. It's coming from hospitals, laboratory examinations, image data, genetic data, cloud data sharing, and also electronic medical record. In IVF, of course, it's very important the data that coming from clinical IVF clinic and also coming from IVF laboratory, which is including sperms, oocyte, and also embryo imagings. And then data processing, becoming model selections by doing by NLP and machine learning. This is all already explained by Professor Hanry. And then becoming models and evaluation, validation, and then we can apply in our daily practice. This is the example of decision tree model in who is conducted, which is conducted to make a predictions for the selections of embryos. This model separates cumulus cell samples upon the entire hormone receptor 2 expressions, high or low, and then upon the chemic inhibitory factor expressions, high or low. This is for doing how we can differentiate high quality embryo and low quality embryo. This is the sample preparations. This is using the SVM. This is using the artificial neural networks. And for the B, this is the sample how we use AI to predict the sperm, the best sperms. And then this is the C is create artificial neural network to product decision support system that can predict the semen parameters based on data collected. This is the sample how people develop AI to predict the best embryos and also to predict the best sperm. Now the things also is just published in 2018 that deep learning was used as a predictive tools for fetal head pregnancy following time-lapse incubations and blastocyst transfer. Yes, this is very important. How deep learning can predict the probability of pregnancy with fetal heart. This is healthy baby. If we replace one embryo, how many percent that one embryo, that single embryo was transferred can become singleton baby intrauterine? So that's why they use the deep learning method by using time-lapse morphokinetic embryos. This is the combinations between time-lapse morphokinetic embryo. This is the incubator who can observe or monitor very details time to time the embryo cleavage, and then in combination with deep learning, they can make classifications which one is the best embryos to be replaced in the endometrium. And how the evidence so far, this is the use of artificial intelligence and machine learning for human reproductions and embryology that were presented at American Society of Reproductive Medicine conference and also European Society of Human Reproductive and Embryologists annual conference, which is performed annually. And this year, one of this conference was conducted virtually. In 2018, at least there are 16 AI and machine learning approach paper. This is nearly every aspect of patient care that we have already discussed, including sperm morphology, sperm identifications, identifications of empty or oocyte containing follicles, predicting embryo cell stage, predicting blastocyst formation, assessing human blastocyst, predicting live birth, improving embryo selection. This is for examples. This is algorithms and or architecture were developed based on this paper. This is, for example, this five paper. This is for the blastocyst formation prediction, assessing human blastocyst quality, and then efficacy in embryo selections, and also embryo selection using AI and also deep neural network. So we can conclude that artificial intelligence AI in reproductive medicine could boost IVF success. This is the data is coming from thousands of embryo time-lapse videos, and then using the deep learning, you can predict fetal heart probability of each embryo, whether 45%, 75%, 25%, or even less than 10%. So AI is more accurate than an embryologist, an expert who doing manipulations toward gametes and also embryos during IVF practices. This is already commercially available. This is the INDONESIA endometrial receptivity analysis that was established by Spain group IVI Valencia. This consists of the expression of 238 genes that we can use to predict whether the endometrium receptive or not. This is one of example, the precision reproductive medicine in the field of IVF. This is what we are doing in IMERI. We just established a system, automated grading embryo system, trying to improve our quality of services in IVF by making the algorithm, the platform, the patterns for helping the embryologist in grading the embryo, which one is the best embryos that could become blastocysts. So this is a source of data, 1,226 data coming from our clinics, and doing the image cropping and annotations of the embryos manually. And then all the embryo data is processed by using deep learning with ResNet 50 and convolutional neural network, and then becoming algorithm that coming from deep learning using the fast AI PyTorch language. Yeah, this is for examples. This is automated grading embryos. Before that, this is the embryos get grade 3 and grade 2, and this is grade 1. This is annotated by embryologists manually by the same embryologist, and then we convert after doing labeling, the grading manually, and then we convert into algorithm and then train and test the grade 1, 300 embryos, grade 2, 400 embryos, grade 3 is 100 embryos. But unfortunately, we don't have the sufficient number of the grade 4 embryos. Yeah, because it's very scanty, very few that our clinic have the poor embryo quality, including the grade 4 of embryos. This is, for example, this is the time-lapse morphokinetic incubator. We can see this one. This is a pronucleus, and then this is embryo was cleavage, time by time, day by day. We can see how embryo cleavage into 4 cells, into 8 cells, into morula, and even into blastocyst. So that's why all the picture, all the video, all the image that were coming from this time-lapse morphokinetic incubator, we can do analysis into the algorithm, into the platform that can predict which one is the best embryos that can become a singleton healthy baby. This is the morula, for examples, and then the last few is for blastocyst formations of the embryos. Yeah, we can see here. Yeah, this is blastocyst, expands blastocyst. Which blastosol, this is the top factor ICM, inner cell mass. This is a top factor that will become the placenta. This is hatch. The inner cell mass was hatched and then going into uterine cavity and then implanted into endometrium. This is one of the papers that was just published, human blastocyst classification after IVF using deep learning. This is coming, the data is coming from our clinic that I've already explained before. Is the next full IVF laboratory mechanization toward robotic-assisted reproduction? Of course. This is we think that we need an automatization or robotization in ART lab. So this is very important, how we can collect the data, then we can do big data analytics very well, and then convert into platform, into algorithm, and then becoming automatization or robotics. And the last, of course, how all of the patients really hope to get pregnant. Sometimes they don't care how much the cost that they should pay for the treatment, because adoption of the latest technology is very important in improving the quality of services and also improving the success rate in IVF. How time to healthy singleton delivery could affect decision making during infertility treatment. Longer the patients married, they are more stronger and more dare to decide to adopt latest technology to improving the success rate. So that's why the big data is a key important point. The electronic medical record is key important point, and also data imaging system, the storage system is very important if you want to make a good AI, particularly in IVF. This is, for example, all the cutting edge technology in reproductive medicine, when one of them is the artificial intelligence. The last as a take-home message, we know that big data is revolutionizing healthcare, including assisted reproductive technology services. And then the development of AI in reproductive medicine particularly is very important to select which one is the best gametes and which one is the best embryos. And after we use the big data, using the bioinformatician and using AI, so we can shape that reproductive medicines is also is precision medicine services, like in precision reproductive medicine. Thank you very much for your kind attention.
Thank you very much for Professor Budi Wiweko. I will say thank you to all the speakers. Now we have 20 minutes for the discussion, and everyone who wants to ask the question, I will give the opportunity to raise your hand and then open your microphone, and you can directly ask the question to the speaker. We will have two sessions. I will give 2 sessions. For each session, we open around 3 questions first. Maybe first I would like ask the question to Professor Hanry. Professor Hanry, about the telepathology, is there any the quality control? I mean, in every 3 months or 4 months, you perform the quality control about the telepathology. And then the second question is about the score. I saw that there is the specific score in liver fibrosis. Is that the score that built by this machine and without using the regular score? And then the third question for Professor Budi Wiweko. The first question I will ask about the big data and the NLP. You said about the big data. Have you already used the big data in using your own computer or using the cloud? And how the comparison between the using the cloud and also the your own the big data in your hospital, for example, like that, and based on the quality and also the safety and the security and so on. And then about the NLP, you said about the NLP is such like a machine that can to collect all of your data and then perform like making the decision tree like that, and then also do the sum statistically and so on. Is that automatically, or there is something should be setting, or there's someone should be the operator of that NLP? Thank you very much. I give the I give the opportunity first to Professor Hanry to answer the question. You got the question?
Yes. Okay, thank you for the questions. The 2 questions, the first question is about quality control. Yes. The second question is regarding the scoring, whether it's done by machine or it's done by pathologist.
Yes, that's right.
Yeah. So the first question is about quality control. Quality control in each laboratory, certainly they have performed quality control, but each laboratory in different clinics and hospitals, they are actually behaving very differently. So that we see a great deviations of qualities from samples from, in one of the trials, we have data from Pakistan, we have a trial from Thailand, we have data from China, China's from different hospitals in China. The quality basically varies greatly. Everybody do perform the quality controls, but still the quality varies. In terms of sample, in terms of imaging modalities, in terms of the data processing, And the data can be saved in a different, wrong format. And so everything is messed up. So when we transmit the data to get some ground truths by pathologists in Singapore, and one of the pathologists keeps on complaining, saying, "Oh, I cannot use this. This data is no good." So that sort of is related to the second questions, whether the scores we have is done by the machine or done by the pathologist. The machine only learns how the pathologist was doing. In fact, I was rushing through my data, so I didn't explain because I was preparing, like last time it was a 60-minute talk, so so I have to cut to half. So
No problem.
anyhow, so what happened is that, in fact, my point I want to make is that deep learning works very well for either very large data or data which is not highly variable. So when I talk about big data, people in the machine learning or AI talk about big data. They're really talking about hundreds of millions or at least a million data point. So they're not talking about a few thousand or few hundred data point. So when we have even a large population like Indonesia or China, and when you talk about what the disease classification, for each specific stage, the sample is not balanced. The number is at most in the hundreds. It's very rare to get to the thousands. So therefore, for machine learning, if you rely upon such small data sets to perform the deep learning approach, often it doesn't work very well if the sample variation is high across different centers. So that's the reason why I was proposing that we have to more put in the experts' opinions from the pathologists by using ground truths from the very experienced pathologists. Try to embed them in the computer systems, in the normal classical machine learning approach. By doing so, it's not so automatic. It has to be retrained, but it's more accurate. So that means we cannot replace pathologists. We can just help, like, many people have talked about this over the years. That is, what's the importance of doctors and what's the importance of pathologists? They are very important.
Thank you very much, Prof. And sorry about the score. Is that the
score is generated by the machine, but the reason why the scores was very good is because they are trained by the pathologist way of classifying disease and the scoring diseases. For example, where is the collagen distributed? Is it in the portal region or is it in the central vein region, in the septal regions or in the rest of the fibrillar collagen? But what does it look like? Where is it exactly in the tissue it's distributed? That's what normally a pathologist do things. But by using deep learning approach, the machine doesn't care where they are. But when we use the classical machine learning approach, by embedding the spatial distribution criteria of pathologists into the machine, we can actually enhance the performance.
Thank you very much, Professor Hanry. And now the opportunity to Professor Budi Wiweko. Please.
Yes, thank you, Dr. Chyntia. Your question is absolutely correct. The number one, as Professor Hanry, you mentioned, if we talk about big data, we don't mention about 100,000, even maybe a million data that we should provide. We should keep the with the good storage and more security, as you mentioned. Nowadays, I think many providers offering their capacity, their competency to make storage system storage. All the storage system was cloud-based, and is it very practical and safe and also secure? I think in IMERI right now, we are preparing to make this big data storage in collaboration with Amazon Web Service, and also Google and also Samsung. We have three candidate providers that we want to setting up the big data storage in IMERI. I think they also offering the services for until using ML for or AI for big data analytics. So compared to we build by our own, using the providers offering is much more better and a lot of benefit for us and advantages. And according to our experience as well in Yasmin IVF clinics or in IMERI, in Riset working group of reproductive medicines, we have a collaborations with our partner, and also they have a cloud-based storage that we establish our algorithm for making automatic grading of embryos. And still, this is still few number. I think only up to 2000 data image. We know that in data image, this very big size, and also we need graphic processing unit, a GPU with like a super performant computer to analyze this data imaging. And as Professor Hanry you mentioned, we should train more of AI to become clever and then become high sensitive and high accuracy and precision in prediction. This is the number one. And in number two, we know that NLP is one of the artificial intelligence that help machines reading the text by simulating the human ability to understand language. So NLP will help the computers understand the sentence as they are spoken or written by a human. So we use NLP for translate the conversation between doctors and patients directly into the written into the sentence. And I think in Indonesia we have a collaboration with the Solusi 247, and the NLP in Indonesian language is already established by Solusi 247 with Rumah Sakit Harapan Kita. So the model was established already with some sentence in Bahasa and also some sentence in dialect in Indonesian traditional language. It will help a lot for us to collect a good collection of data that coming from the clinical sites to convert into electronic health record that will support the establishment of AI. This is Dr. Chyntia. Thank you.
Thank you very much, Professor Wiweko. And about machine learning, we already have the machine learning.
Yeah, this is the software. Yeah, actually we have a software, a lot of models. There's some open source software as well.
Okay.
Nime, yeah, a lot, Orange or Nime. There's some, or this is the open source, but sometimes we should buy also the software like Python. Yeah, there's some training that we have already established in IMERI for artificial intelligence in medicine.
Okay, thank you very much, Professor Wiweko. And this is in the chat. We have some question. Okay, the first question is about maybe for both of the speaker about the issue of ethical issue. Actually, this is AI is maybe too far in the future to be used in daily practice, but however, it can be very important for the data. And how is about the ethical conflict in each field while using AI? Is it safe or will not cause any conflict in research? This is the first question for both of the speaker. And then the second question is about the problem related with the virus in certain program that might ruin the research data. How about that? How about that issue? Is there any solution or any software that can protect the program from the virus attack? And then that is for both of you also. And then this is the third question. For Professor Hanry, with AI, the tools for staging liver fibrosis, how about the result in Singapore? Can it already applied clinically directly, or should we conform it to pathologists? And then for Professor Budi Wiweko, I'm very interesting the statement that artificial intelligence is not everything, because most of people nowadays said that AI can replace any profession. How far the AI and NLP implementing the development of IVF AI in Indonesia? And maybe the last question from Dr. Muhammad Alkaf, for the e-data in the storage and for the storage and the usage of the e-data for the service and research, it should be based on the rules or no about the privacy of the patient. And maybe it rather the same like the first question about the ethical issue. Please, for both of you to answer the question. Maybe first, Professor Hanry, would you like to answer the first question about the ethical issue?
Maybe I can defer the ethical question first to Professor Wiweko, because I think I'm in a relatively technical aspect of research areas. So I think it concerns the medical community more.
Okay, so you mean in your area, it would not be very disturbed or disrupted by the ethical issue, right?
There are standard ethical practices, such as you have to get IRB to approve certain trials, things. And those are very standard stuff. And how to handle patient samples. Our clinicians have strict guidelines in terms of what we can do, what we cannot do with the data. So we are more or less on the more practical and technical side of the equations. So we just comply with whatever they told us.
And then the second question for you is about the staging of liver fibrosis, whether directly or will be confirmed to pathologists when perform one examination like that.
Right. So there are a couple of aspects to response to this question. Firstly, the kind of data I show you, other than SHG using machine, which is commercially available. There's a company called HistoIndex, which is selling a machine. And so that somehow helped the process a little bit. They provide services. But if you want to talk about SQ fibrosis, the final scores, which I shared, which can be applied, and people can download the software and put data in there, analyze themselves. That work has not been published yet. So this is unpublished data, my collaborators in different countries has been chasing me for getting the paper published. And so we want to publish the data and then make people use them more and more. But please, the second aspect of the response is that the whole concept is that because of the lack of large data, big data, is really lacking in the clinical setting for different type of disease or different stages of disease. So therefore, we cannot totally rely upon the system without retraining them. So as you notice in the scenario 2 versus scenario 1 doesn't retrain them. So the performance is worse than in the scenario 2 when you have to retrain the system with local data. So as a result of that, you need some. The best answer, the simplest answer is that if you don't have a choice, you can use this as an aid. If you have a choice, please talk to experienced pathologists.
Thank you very much, Professor Hanry. And I give the opportunity to Professor Budi Wiweko to answer the question, maybe about the ethical issue, about the data, and also about the NLP implementation in IFF AI in Indonesia.
Thank you, Dr. Chyntia. Yes, regarding the ethical issue, this is quite right. So that's why we need, in Indonesia, we have actually the regulations, President's decree regarding the Satu Data Indonesia, but still not covering the Satu Data Kesehatan, One Health data, One Health big data regulation in Indonesia. So we need to cover this one. So there's one authoritative body that is like a super body, that regulating all health big data issue in Indonesia, including the data collections, including the regulations such as security, confidentiality, accessibility, how who can be shared this information, intellectual property rights. This is all should be regulated by one super body. And also the next, also including the big data analytics. It is also very important ones. And how actually the big data is becoming a new oil in health. It's such as industry. If you talk about big data, there is no privacy in big data. With the very important point, this is anonymous big data, no privacy. We can see if we open the website, GSAID, Global Initiative Sharing All Influential Data. It's more than 100,000 data of SARS-CoV-2 is already published there. It's very important for people in the world to create antibody, to create vaccines with the big data. So that's why no privacy in big data. But very interesting in US, now they need the informed consent must be taken to every patient regarding their genomic data. So we should asking the permission of the patients to give their genomic data, not only clinical data, but also genomic data. This is very interesting one. So regarding the practices, of course, as a medical practitioner, I'm quite confident that artificial intelligence or robot is not replacing our daily practice. They only enhance our capacity. They only enhance our competence to give more precise, more accurate in health services to the patients. They are not replacing. So that's why the very important for us is adaptation. Is much more important than adoption. If we look the scoring system, automatization in medicines, level 5, level 1 to level 5, maybe in medicine only level 3, not even more than 3, up to 4, maybe only level 3. How this is the role of AI and robotics in our daily practice. So still we need empathy. Robot, even Sophie, people mention that Sophie is humanized robot, but people cannot feeling well how the robot can express their empathy to the patients. So doctor, as a doctor, of course, we can express our empathy to the patient much more better than robot, our professionalism, something like that. And then in reproductive medicine as well, in Indonesia, currently, we use the AI in order to make automatic grading of embryo. This is number one. And also, we use the time-lapse morphokinetic incubator, including the algorithm inside, to decide which one is the best embryos to be replaced to the women in order to improving the high success rate. I think this is the third Chyntia. Anyone left?
No. Thank you very much, Professor Budi Wiweko and Professor Hanry. I think because of the time, I would like to thank you for all of you, to the speaker, and also for the attendance for this session. Before we finish our session, I would like to make a conclusion from our presentation today. Is that about nowadays we have got many challenges. We are now in the era of VUCA, volatile, uncertainty, complexity, ambiguity, and then globalization, and then 4.0 industry era, and also we got the challenge again in COVID-19 era. Actually, COVID-19 is like the challenge that include in what I have already talked before. And if we face the technology, it doesn't mean that we have to refuse that, or we just accept it all without any adaptation. We have to adapt it with every change in the world. If we cannot follow the globalization and the technology progression, so we will be left. So actually, even though there is the progression of the industry, we still a doctor, we still need to perform the value-based medicine. I think that is all the conclusion of this session. And then I give the session to the MC.
Okay, thank you very much, Dr. Chyntia. Thank you very much, Professor Hanry and Professor Budi Wiweko for the amazing presentations. Now we have a very good understanding about artificial intelligence and its application and in various research fields. And I give my very big thanks to Dr. Chyntia and all of the participants who have been very active in the discussion. It makes our discussion become more interesting. Okay, before we end this session, I would love to take a picture of all participants in this webinar. So to all participants, please turn on your camera and give a pose while admin is taking our picture. Okay. Okay, it's belum semua. Okay, I will start counting. 3, 2, 1, smile. One more time. 3, 2, 1, smile. Okay. Okay, thank you very much for all participants and for Professor Hanry and for Professor Budi Wiweko and Dr. Chyntia for the presentation today. And we are only arrived in the end of the session. And I remind to all participants to fill in attendance link before leaving the Zoom meeting. The link will be
Thank
and
you.
I, representing webinar committee, apologize to any mistakes and shortcomings during this webinar. Thank you for your coming and see you in the next webinar series. Okay, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Professor Hanry.